Plantar fasciitis is a controversial topic. Even the name should be controversial because we're talking about something which has not too much inflammatory changes, but rather thickening and degenerative tissue findings around the plantar fascia. So we might properly call it plantar fasciopathy, but this is still a term we're not very much familiar with. So I will still refer to plantar fasciitis this afternoon. The facts with plantar fasciitis is that 1 out of 10 of us will suffer from plantar fasciitis anytime in our lifetime, and fortunately, most of them do resolve without surgery. Around 90% of cases do resolve with a surgery, but it usually takes long, as you all know from your practice. So around 10 months from the onset of symptoms. So one of the questions is that we should possibly not do surgery before that time, because most of them will resolve without resorting to surgery. You're all familiar with the startup pain, with tenderness at the plantar medial proximal insertion of plantar fascia. We should be ruling out other problems around the heel. So that's basically why we ask for image studies, because clinical diagnosis is common. Regarding image studies, heel spores are not significantly associated to plantar fasciitis, although there is a higher incidence of heel spores in patients with plantar fasciitis, but there's no evidence correlating one thing to another. So again, there's no correlation with accessing a heel spore with getting a better outcome with plantar fasciitis. And there is also no apparent correlation between thickness and pain. So some orthopedic surgeons do still measure thickness of plantar fascia as a way to indicate surgery, but unfortunately, again, there's no much evidence on that. So no real correlation between thickness and pain in patients, and there's no correlation back after surgery with thickness and pain as well. So we should be ruling out other causes of heel pain. Whenever I get a patient to surgery, I do ask for a routine MRI study, just to rule out any tumors or anything like that could actually have an influence on my practice, on my surgery. But most of the times what we find is thickening of fascia and no on the plantar fascia. Of course, we should rule out any inflammatory conditions that again might influence treatment. But this is very occasionally the case in which you actually send the patient to a rheumatologist because it has an inflammatory condition. We should be suspecting that if we have a bilateral case of plantar fasciitis, long-standing pain. We still don't know why plantar fasciitis is actually started in many patients. So etiology is largely unknown. Some colleagues have been trying to study risk factors for a long time. It seems that age does have an influence, significant influence, so possibly because of decreased shock-absorbing capabilities. We're suffering more and more plantar fasciitis as we get older. No other differences. Body weight does have an impact on plantar fasciitis. Overweight people have more incidence of plantar fasciitis. Lifetime occupational, recreational running, military activities, and Irish step dancing have been potentially correlated and significantly correlated to plantar fasciitis. But with some of us, we don't have that. I don't know if there's any Irish colleague around, but this is step dancing, Galway. Emma Sullivan is that lady, and possibly the amount of shocking, or possibly the type of shoe also influences that. But most of our patients do not have these activities, so there's not much influence on what they do and how many hours do they spend walking around. Systemic disease do have an impact, so that is definitely a risk factor, but again, this is very occasional in our patients. Nerve entrapment, Baxter nerve was usually associated to plantar fasciitis, but interestingly enough, over the last few years, this has lost evidence and power. The symptoms we can get from some patients with nerve symptoms could be actually secondary to swelling or to the environment of the Baxter nerve. But we know that many of these patients, when we get a procedure, whatever the procedure, that get the patient better, then nerve symptoms possibly go away by themselves. So it was a trend a long time ago, in the 1980s, to systematically release the Baxter nerve. It is not done now systematically in most of our practices. Pathomechanics is an interesting issue. We do a lot of clinical research on mechanics and why things happen around the foot and ankle. And it was interesting to know that in the 1990s, most orthopedic surgeons were worried on the complications of plantar fasciotomy because they were getting patients with lateral column destabilization, lateral column pain, and what they call lateral column syndrome following fasciotomy, and then worries again on medial arch collapse. And that was the worries a long time ago, but over the years, the worries have been different. The worries have been on recognizing associated pathology and on actually wondering why plantar fasciitis happen, and also why plantar fasciitis takes 3 months to resolve in some patients, and it takes 3 years to resolve in other patients. So this is what we've been working on for the last 15 years in my practice. Flat feet, gastrocontracture, severe hallux valgus. We know that there's a strong correlations between some of these conditions and the development of a chronic recalcitrant plantar fasciitis. We started thinking of the sagittal plane as an important factor for plantar fasciitis a long time ago. We know by the works of Viladot a long time ago, 1950s, that there is a system between the Achilles, the calcaneus, the os calcis, and the plantar fascia that works together. And that is an important factor that we've been lately rediscovering as a part of an explanation for the pathomechanics of plantar fasciitis. And over the last 10 years, there's been papers and papers on the relationship between gastrocnemius tightness and plantar fasciitis and other conditions around the foot and ankle. If we have a look at the Perry, the gait analysis by Perry, plantar fasciitis might be generated at the end of the second roca. We know by the studies of Higgs and others, if we have a look at gait analysis, that at the end of the second roca of gait, full knee extension should be coupled to ankle dorsiflexion. So ideally, when the knee is extended, the dorsiflexion of the ankle should be neutral, should be around 90 degrees. And that is fine as long as you have elastic gastrocnemius. But if you don't, you will then generate forces, reaction forces from the ground to the plantar fascia. The windlass mechanism will not work properly any longer. So we've been actually studying for a long time on the correlations between assault gastrocnemius and the development and perpetuation of plantar fasciitis in some patients. So we know that the inability to have a fully extended knee with the neutral ankle would actually cause damage to the plantar fascia. And if we do repeat that 9,000 times a day, that will cause damage to the plantar fascia. That's a subtle damage, sometimes a subtle equinus that we find in some patients. Neil Silvershell developed a testing on how to examine this echinism. So you all know that the ankle dorsiflexes with the knee flexion, and it doesn't dorsiflex and doesn't reach 90 degrees with the knee extended. That is a positive test that shows the echinism is gastroc-dependent. So gastroc-dependent echinism is possibly a factor that influences plantar fasciitis. Most of us do have short gastrocnemius, and that is because of evolutions. Not so many million years ago, we were quadrupeds. So we had quadruple gait, and now we became, we had a bipodal gait. So that is possibly influenced that. If it does prove true in a few million years, possibly, there will be no more plantar fasciitis on Earth. I don't know if that will be the case, but this is possibly evolution from where we come from. And that is clearly an important factor that we've been researching over the last year. So if most of us do have short gastrocnemius, why don't we all suffer from plantar fasciitis? Why just 1 out of 10 people do suffer from plantar fasciitis? Because the foot and ankle have a lot of mechanisms to compensate for that. You will possibly have, of course, this type of gait. This is what we call the bouncy gait, in which some patients do have external rotation, some flat foot deformity, which is flexible, which is non-dysfunctional, but this accounts for compensatory mechanisms to get rid of that mechanism in which the plantar fascia is stretched too much with every step. So most compensatory mechanisms do allow for patients not to develop plantar fasciitis. But when these mechanisms do not work properly, then patients are prone to have plantar fasciitis. How about treatment? Well, we all know that conservative treatment is the key for most cases. 90% of cases will resolve without surgery. And the most important conservative treatment is talking to the patient, telling the patient to be patient. And that's not easy because our time is very costly. And it takes time to actually explain to the patient that it will resolve and eventually. Most patients do understand that, and they do well on conservative treatment. And again, regarding conservative treatment, there's a wide variability for that. Di Giovanni performed and conducted a study 2012 among foot and ankle surgeons in the US, and they asked him what to do with chronic plantar fasciitis 4 months down the line. Most of these colleagues do recommended plantar fascia specific stretching exercises. But at 10 months, most of them would go for extracorporeal shockwave therapy or surgery. And then when they examined the type of surgery, there was a tremendous wide variability of surgeries. So not much help on that, except for plantar fascia specific stretching exercises. Apparently, there's no evidence between orthotics and splinting and success treating plantar fasciitis, except for night splints. Although, night splints are actually associated with poor patient tolerance and compliance. But they apparently do find in a limited study. There's no evidence for injections. There's no evidence for platelet-rich plasma. There's only evidence on short-term results, but not on long-term results. They do get better for time, but not on the long run. And no evidence for strengthening exercises of the foot and ankle muscles. But there's apparently evidence for extracorporeal shockwave therapy. But we don't have that available. Insurance companies do not reimburse extracorporeal wave therapy in most of our places. And it's interesting to notice that patients who had short gastrocnemius do respond worse to this therapy. So there's something which points to the gastrocs as a part of the problem. And then there is evidence, strong evidence with stretching exercises, the eccentric loading exercises by Alfredson that we routinely use for the Achilles non-insertional tendinopathy. They do work fine for plantar fasciitis. The problem in our practice is that patients don't really know how to do eccentric loading exercises. So we set up these videos with explanations that patients can download. We can send them to the patient. And those patients who are really compliant, they do get well with that. So this is our first line of treatment, of orthopedic treatment, conservative treatment for patients with a chronic plantar fasciitis, regardless of the time from the onset of symptoms. We do not operate anyone without getting them into these 2 months, 2 times a day, stretching eccentric loading exercises. Most of them do get fine and do not need surgery. Regarding surgical treatment, again, we have a great variability, retrospective studies, level 3, 4, 4.5 evidence. So, again, there are many possibilities to do that. Partial proximal fasciotomy, open endoscopic, nerve decompression, both combined. There's so many different possibilities to do that. I'm not trying to convince you over what to do because possibly you will do different type of things and you're possibly happy with them. I'm going to take you a small trip of my experience, what been my experience over the last 20 years. And it seems to sort of correlate with the literature somehow. And in the 1980s, the apparently preferred method of treatment for chronic recalcitrant plantar fasciitis was a combination of a open proximal plantar release with the release of the Baxter nerve. And that was a trend at the time. But then if you have a look at the 1990s, the nerve apparently was not so important, so open proximal plantar release was okay for most surgeons at the time. But if you have a look at the literature, there's something which is funny and curious to analyze. There was no consensus over the amount of fascia to be incised. When I started off in the foot and ankle practice, my mentor said, well, just take around the medial third release and do not much because otherwise you will get the patient to have lateral column pain and the medial arch collapse would be a problem. So I was very conservative on that, but you have a look at the literature, this is funny. The same authors did recommend the complete release of the plantar fascia in 1991. A couple of years later, they said the medial 2/3 of the fascia should be incised. And a couple of years later, the same author says that just the medial proximal third of the fascia should be incised. So, as you see, this is, I believe, something which is very much significant. And this is the way we did practice a long time ago. When I started my practice, 1999, I did that. What I used to do was a proximal open plantar fasciotomy, just doing the medial third of that. But it was frustrating in my experience that I operated the same type of patient, the same morning, same surgeon, same technique, and one patient did fabulously and the other miserably. So there was something missing in that. I knew there was something missing. So in my honest experience, I only could get around 75 to 80% of good results, which is very poor, because 2 out of 10 patients didn't get better with my technique, with my fasciotomy. And fortunately enough, I met Mark Davis at the time. He was actually doing a fellowship with Saxby in Australia, and he published this paper saying that in their hands, surgical treatment was again poor. So that was striking for us. So there was something missing, and there was something mechanical going on that we couldn't actually explain in our patients. So we started to look at those patients who were not good after surgery, and most patients did have a so-called gastrocnemius. So we started to think on the sagittal plane to actually find an explanation for that and try to close the gap on our results on those patients who were particularly badly after surgery. So that was a brainstorming. That was around 18 years ago that we did this brainstorming, and we were convinced that we needed to lengthen the triceps in order for those patients to get better. The problem is where to lengthen the triceps. You have such a big variety of triceps lengthening that what to choose for our procedure, for our patients. Apparently, the lower you go, the closer to the foot you go, the more powerful the release is, but the more iatrogenic it gets. So so we were very worried on causing lengthening of the triceps at the time, and we started thinking to start with the 5 anatomic level, the proximal release was our first bet to go, because we were worried on getting lengthening and getting loss of calf power in those patients. So we found out that Samuel and Pierre Baruch in Bordeaux were starting to perform proximal gastrocnemius release for some patients. So we flew to Bordeaux and we met Samuel and Pierre, and they were doing this for a variety of conditions in the foot and ankle, metatarsalgias, plantar fasciitis, and they were happy, and we were able to see that their patients were happy as well. So that was, we brought that home to Madrid. They were actually cutting both gastrocnemius, medial and lateral gastrocnemius. And that was the initial pictures by Samuel and Pierre. And that was 2002, I believe, 2003 when we did that. So Samuel came to Madrid. We had over dinner, have some talks on that. We started doing the proximal gastrocnemius release, and that was truly good for us. We started to have good results at the beginning, and we again knew that there was somebody in London who were performing some clinical research and cadaver research on proximal medial gastrocnemius release, and that was Matt Solan and Mark Davis from the London Foot and Ankle Centre that was doing that. So we flew to London, met them, and see what we're doing. And it was interesting. There was an interesting cadaveric study in which they demonstrated that it was the medial gastrocnemius head that was more powerful, and we could actually we could miss the lateral release at all. And they were apparently having the same results with just the proximal medial gastrocnemius release than the Baruchs were getting with releasing both heads. So we started to skip the lateral head, and we stick to just releasing the proximal medial head of the gastrocs. And then a few papers started to arise on the subject for different foot and ankle conditions. So a few years later, we said, well, we got it, and what we did was to divide our experiences. So Matt and Mark started to publish on their experience with plantar fascia release, and we published our experience with a comparison of plantar fascia release versus gastrocnemius release. And what we do now as a first-line treatment, we've been doing that for a long time, almost 15 years now. We do this incision of the medial gastrocnemius head. It depends on the size of your toe, of your finger, possibly a couple of centimeters more than most of you, but it could be worse if I was a neurologist. But what I do with that is get on local anesthesia and sedation of the patient. So you just got local anesthesia on the skin. There are no nerves around the head of the gastrocnemius. As long as you don't touch deep inside the joint, there's no pain on doing that on local anesthesia. You get your finger, you actually check, you have the medial gastrocnemius head, you're not getting the hamstrings or whatever. So once you follow the shape of the medial gastrocnemius head, you use a blunt instrument to externalize the head so that you're not damaging anything, and you cut the fascia, you cut the white stuff there, and you have to be sure you cut the whole fascia. The fascia is not flat, it does get a small round shape, and once you have that, you can get actually dorsiflexion of the ankle quite easily. It takes a few minutes to do the surgery. And when we analyze the results from our experience comparing proximal medial gastric release versus plantar fasciotomy, what we found out that in our study comprising 60 patients in all, with all these variables, it was clear that medial head was enough, local anesthesia, day procedure, easier post-op regime that they had with the plantar fasciotomy, pretty quick to go back to sport daily activities with the proximal medial head release versus the plantar fasciotomy that we had. We had worse results with proximal partial fasciotomy that we had with the proximal medial gastric release. And in terms of functional and pain scores, again, proximal medial gastric release was far better than we had with our fasciotomy patients. And again, with patient satisfaction. Complications were less with the proximal medial gastric release as well. And we found some interesting facts in this. The pre-op duration of symptoms didn't have any influence on the final outcome in our patients. And it didn't have any influence with the previous treatments as well. So, fortunately enough, none of our patients got worse, and around 90% of patients were satisfied. That was far from the 75 to 80% with the proximal partial release. So it fortunately compares better. Others' group experience is, again, highly satisfactory with this. And our main worry was loss of calf power in athletes. We started doing that in amateur athletes, and it didn't have any sort of calf power, apparently. So this is an athlete we operated 3 months before the Olympics in London, and she made it to the Olympics with a gastric release plantar fasciitis for a long time. So no loss of calf power in athletes. And I would just like to finish my talk with something which has been interesting enough with these patients. So over the time, you possibly may have patients who say, well, I have a plantar fasciitis, but my leg is in pain, my hip is in pain, my back is in pain. I say, well, okay, let's get on with the plantar fascia first. There's something which we call gastrocnemius syndrome, and this is an association of things that are not by coincidence. So this is not a coincidental thing, that these patients with short gastrocnemius do have more incidence of other associated injuries. So they usually suffer from plantar fasciitis, Achilles non-insertional tendinopathy, second rocker metatarsalgia, sinus splints, and the association of all of them during their athletic careers, it is what we call gastrocnemius syndrome. And it, again, should be treated with a gastric release. In our hands, it has a staggering influence on their history of injuries when they keep on playing. So the take-home message would be plantar fasciopathy is, again, controversial. We know 90% of cases will resolve without surgery. We do feel that gastrocnemius shortening is something that we should be considering as pathomechanics of the problem. Stretching exercises, extensive loading exercises, is our first-line treatment for conservative management of this condition. And the isolated proximal middle gastrocnemius release has been the first-line treatment of choice when we consider surgery. So in our hands, it has better results than fasciotomy. And think of gastrocnemius syndrome in your patients as well, because they may get better as well with gastro release. They didn't get better with a proximal fasciotomy in the past. You may find details of all that in this paper we published a few months ago, and that's the OrthoReviews journal that you all have in your bags, I believe. Thank you so much.